welcome to the Deep Dive. Today, we're tackling something that can feel, well, pretty confusing, maybe even a bit alarming, those lab results for blood sugar. Numbers like fasting glucose or HbA1c. We're going to decode them.
Yeah, it's often a bit of a shock when you get those numbers back. They look technical, maybe just like statistics on a page.
Right.
But they're actually really profound signals from your body about your metabolic health, especially long term.
Exactly. So our mission today is really for you listening. We're going beyond just definitions. We want to translate the specific standards, set by big organizations like the WHO or, say, the Korean Diabetes Association.
And explain why managing these numbers consistently is so crucial.
Especially if you're maybe dealing with prediabetes or perhaps you've just been diagnosed. We want you to feel empowered, not confused.
Absolutely. Stop seeing them as scary statistics. Start seeing them as tools for proactive management.
Okay, let's unpack this then. Let's start at the beginning. What are the actual clear numbers that signal a shift from healthy towards prediabetes or even a full diabetes diagnosis?
Okay, so there are three main ways we diagnose, three primary standards. The first one, probably the most common, is the fasting plasma glucose, your FPG.
Okay, fasting glucose. That means after not eating for a while.
That's right. You need to have fasted for at least 8 hours, so usually done first thing in the morning.
And the numbers.
Right. So if your FPG is below 100 milligrams per deciliter, that's mgdl, you're generally in the clear, considered normal.
Okay.
But if it falls between 100 and 125 milligdl, that's the prediabetes zone. That's a really critical flag.
The warning sign.
Exactly. It means action needs to be taken. And then if your FPG reading is 126 milligdl or higher, well, that meets the diagnostic criteria for diabetes.
That 100 to 125 range, that pre-diabetes zone, that always strikes me as so important. If it's that critical, why the big push for lifestyle changes first instead of jumping straight to medication? Wouldn't medicine be faster, maybe safer?
That's a really thoughtful question. It gets to the heart of what prediabetes is. See, in that range, your body's starting to struggle with insulin resistance, sure, but often the pancreas can still pump out enough insulin to sort of keep things from going completely off the rails. And study after study shows that lifestyle changes, especially things like losing some weight, getting more active, are actually more effective than starting medication early for reversing prediabetes or stopping it from becoming full diabetes.
More effective, really?
Yes, it's like a window of opportunity where you have a powerful chance to potentially turn things around naturally without needing drugs right away.
Okay, that clarifies why it's a proactive choice then.
Yeah.
So, moving on, what's the second pillar? You mentioned testing the system under stress.
Right. That would be the 2-hour plasma glucose reading. This is usually part of what's called an oral glucose tolerance test, or OGTT.
The sugary drink test?
Pretty much, yeah. You drink a standard 75-gram glucose solution, and then we check your blood sugar exactly 2 hours later.
And the threshold there.
If that 2-hour reading is 200 milligdl or higher, that also meets the criteria for a diabetes diagnosis. It shows how well or how poorly your body clears that sugar load.
Got it. So FPG, OGTT. What's the third piece of this diagnostic puzzle?
Well, the third standard kind of has two main options. Option one is based on random plasma glucose, or RPG. That's a blood sugar test taken at any time, regardless of when you last ate.
Right.
If that RPG is 200 milligdl or higher, and this is important, and you're also showing those classic diabetes symptoms.
Like being really thirsty, needing to pee all the time.
Exactly. Polydipsia, the thirst, polyuria, frequent urination, maybe unexplained weight loss too.
Yeah.
If you have the high number plus the symptoms, that counts.
And the other option in this third pillar, you mentioned it earlier.
Yes, and this one is arguably the most important for understanding long-term control. It's the glycated hemoglobin, or HbA1c.
The A1C.
Right. If your HbA1c is 6.5% or higher, that also confirms a diagnosis. And it's worth noting, these thresholds, the FPG of 126, the HbA1c of 6.5%, they're pretty much universally adopted by major health bodies worldwide, like the WHO and the Korean Diabetes Association. That's why you see consistency in guidelines.
Okay, let's really focus on that HbA1c for a moment. We often hear it called the long-term report card, which is a helpful analogy. But what's actually going on chemically? What is the sugar sticking to that makes it reflect things over months? And is that sticking process itself bad for the blood cells?
Great questions, digging into the why. So the HB in HbA1c stands for hemoglobin. That's the protein inside your red blood cells that carries oxygen, right?
Right.
Now, when glucose, sugar, is floating around in your bloodstream, some of it just spontaneously sticks to that hemoglobin. It's a process called glycation. It's kind of like sugar coating the hemoglobin.
Okay.
And the key thing is the more sugar there is in your blood, the more hemoglobin gets glycated or sugared up. And this bond is pretty much irreversible for the life of that red blood cell.
Ah, okay, so it stays stuck.
It stays stuck, and red blood cells have a lifespan of about 120 days, roughly 2 to 3 months. So by measuring the percentage of your hemoglobin that has sugar stuck to it, the HbA1c test gives us a really good average picture of your blood sugar levels over that preceding 2 to 3 month period.
I see. So the 120-day lifespan explains the 2 to 3 month average that clicks.
Exactly. And to your other question, is the glycation itself damaging the cell? Not really the red blood cell directly in a major way, no, but it serves as a fantastic marker, a chemical record of just how high your average blood sugar has been running over time.
That makes so much sense now. So what are specific A1C levels or grades we should know?
Okay, so normal HbA1c is considered below 5.6%, that critical prediabetes range we talked about. For HbA1c, that's 5.7% up to 6.4%.
Right.
And then, as we said, 6.5% or higher confirms a diabetes diagnosis.
And for people who are diagnosed, what's the target then? What are they aiming for in terms of management?
Generally, the main goal for managing diabetes is to keep that HbA1c level below 6.5% or often below 7.0%. The specific target might vary slightly depending on the individual, but that's the typical range.
And why is hitting that target so critical?
Because achieving and maintaining that goal, keeping the A1C consistently in that range, has been proven time and time again to dramatically lower the risk of developing serious microvascular complications.
Microvascular, meaning the tiny blood vessels.
Exactly. Damage to the small, delicate blood vessels in your eyes, your kidneys, your nerves. Keeping A1C down protects those vital systems.
Okay, here's where it gets really interesting, I think. Let's talk about that danger of complacency. Because the symptoms can be so subtle or even absent early on. It's easy for people to think, oh, I feel okay. I don't need to worry about managing this aggressively right now.
Yeah.
What actually happens if someone lets that chronic, maybe silent, high blood sugar just continue unchecked?
That thinking, that I feel fine attitude, is precisely why diabetes often gets called the silent killer. It's a terrible name, but it reflects the danger.
Yeah.
Because even if you feel fine, chronically high blood sugar is doing damage internally. Think of it like fine grit sandpaper constantly circulating through your blood vessels.
Wow.
It slowly, relentlessly damages the delicate inner lining, the endothelium of both small and large blood vessels everywhere in your body. This leads to inflammation, poor circulation, and sets the stage for major problems down the road.
We really need to understand the potential severity here to grasp the urgency. Can you lay out the major complications, the really frightening worst-case scenarios we're trying hard to prevent?
Certainly. We usually group them into two main categories. First, there's the microvascular damage, the damage to those tiny vessels we just mentioned.
Okay.
This includes things like diabetic retinopathy damage to the blood vessels in the back of the eye, which is a leading cause of vision loss and even blindness. Then there's diabetic nephropathy kidney damage. Sadly, this is the single most common reason people end up needing kidney dialysis.
Oh, wow.
And diabetic neuropathy nerve damage. This can cause pain, numbness, tingling, but critically, it often affects the feet, leading to loss of sensation, ulcers that don't heal, and sometimes, tragically, amputation.
That's incredibly serious. And the second category?
The second is the macrovascular damage. This affects the big arteries, the ones supplying your heart and brain.
Okay.
Diabetes dramatically speeds up atherosclerosis, which is the hardening and narrowing of these arteries. This doesn't just slightly increase your risk of major cardiovascular events like heart attacks, myocardial infarction, or strokes.
It multiplies it.
It multiplies it significantly.
Yeah.
Several times, even tens of times higher risk compared to someone without diabetes.
Mhm.
Honestly, in many ways, having unmanaged diabetes is like having active cardiovascular disease already.
That's a powerful way to put it. Cardiovascular disease in disguise. It really highlights the life-altering, life-threatening risks if it's ignored. But, and this is crucial, the good news is management works, right?
Absolutely. That's the vital counterpoint.
Yeah.
We have to reframe the diagnosis. Yes, diabetes is very difficult to actually cure once it develops, but it is entirely possible to live a long, healthy life without these devastating complications if you manage it well.
Mm-hmm.
The diagnosis isn't a sentence, it's more like a roadmap showing you the path you need to take.
Okay, so we've laid out the numbers, the diagnosis, the huge risks of inaction. Let's pivot fully to empowerment now. What are those core evidence-based actions people can take that directly impact those FPG and HbA1c numbers? What works?
The foundation really comes down to lifestyle adjustments because these directly tackle the root issue, which is often insulin resistance. We usually focus on 4 key areas.
Okay, number one.
Number 1 is diet. And it's not just about eating healthy in a vague sense. It's specifically about drastically cutting back on processed sugars and those highly refined carbohydrates, white bread, pasta, sugary drinks. Those things cause big, rapid spikes in blood glucose.
Right, which forces the body to work overtime with insulin.
Precisely. Second is exercise.
Mm.
The general recommendation is aiming for at least 150 minutes of moderate aerobic activity per week. Think brisk walking, cycling, swimming.
Why does exercise help specifically?
Because physical activity makes your muscle cells more sensitive, more responsive to insulin. They can take up glucose from the blood more easily, which helps lower your overall blood sugar levels, including that FPG.
Got it. Diet and exercise. What's number 3?
Number 3 is weight management, especially focusing on reducing visceral fat. That's the fat stored deep around your organs. It's metabolically active in a bad way, worsening insulin resistance. Even modest weight loss can make a big difference.
Okay, and the 4th key area.
Fourth, and this is incredibly important, is quitting smoking. Smoking doesn't directly raise blood sugar in the same way carbs do, but it severely damages blood vessels all on its own.
Ah, so it compounds the risk.
Exponentially. If you have diabetes and you smoke, your risk for those microvascular and especially the macrovascular complications, heart attack, stroke just skyrockets. Quitting is one of the most impactful things you can do.
So diet, exercise, weight management, quitting smoking, these are the actionable steps.
They're your primary defense lines against those serious risks we discussed. They directly help improve your numbers.
This has been incredibly helpful, I think. We've taken those numbers, FPG, HbA1c, from being just confusing stats to being, well, understandable targets. We know the FPG of 126 milli-GDL is that diagnostic line. We know HbA1c of 6.5% confirms it and shows the long-term picture. And for managing it, keeping that A1C ideally below 7%, maybe even 6.5% is the goal.
Exactly. And the main takeaway, I hope, is for you to stop seeing these numbers as just scary or bad news.
Right.
Start seeing them as information. Essential data points that actually give you agency, give you power. They're signals pointing you towards a healthier path, helping you make proactive choices today.
So what does this all mean for you listening? Maybe you have some recent lab results tucked away somewhere. Pull them out. Look at those numbers again, but with this new understanding. See them not as a final verdict, but as that critical roadmap for your health moving forward. And here's a final thought to consider. Since getting and keeping that HbA1c in the target zone below 7%, ideally closer to 6.5%, really hinges on those consistent lifestyle changes. Think about how much control that actually gives you over your long-term health, even with a diagnosis. What's maybe one small, manageable change you could start today? Could you swap one sugary drink for water? Add a 10-minute walk after dinner? What's one step you could take right now to nudge that HbA1c number in the right direction? Just think about that one step and the power it holds. Thanks for diving deep with us.
We'll catch you next time.